Assalamu alaikum. In today's video, we will discuss about hypertensive emergency. This topic is very important for all residents working in emergency medicine department as well as for student. So today I will discuss about what is hypertensive emergency and how you will manage hypertensive emergency. So today I will tell you how to approach stepwise approach how to do stepwise approach to hypertensive emergency. So the first step is to do ABCD approach. ABCD is a normal approach we do in each and every emergency, like we assess the airway, breathing, circulation, and disability, and E is for exposure. So we do all these things in every emergency. Second thing is you found that the patient has a BP higher than, let's suppose you have the patient BP higher than 180 by 120. What you will do with this patient is to admit the patient to either HCU or HDU. It is the high dependency unit and intensive care unit. The third step is once you admit the patient, you will check his BP regular, will keep eye on the pulse of the pressure, it will check the respiratory rate, saturation of oxygen, and temperature monitoring once you admit the patient into ICU or HDU. So the fourth step is to lower the BP using the IV drugs. Once you found that this is a hypertensive emergency, now you will use the IV drugs in order to low down the BP. And the fifth step is to evaluate and treat underlying disorder. What are the underlying disease or disorder which can lead this patient to hypertensive emergency? And the sixth step is sign and symptoms of the end organ damage. Let's suppose patient presented to you with hypertensive emergency, and now you are assessing the patient that either the patient has got end organ damage or not. If the patient has got end organ damage, you will manage accordingly. So we will discuss further. It is very important to look for the sign and symptom of end organ damage. So we look at the four organ, either it is damaged or not. So first we look at the cardiovascular system. Is the patient has got any heart failure exacerbation with hypertensive emergency, or patient has got pulmonary edema, or the patient has got myocardial infarction, or the patient has got aortic dissection. If the patient has hypertensive emergency with any of these, this patient has a different management plan. Let us again go to the neurological to look for the end organ central venous system. If the patient is either hypertensive encephalopathy, the patient with hypertensive encephalopathy will present with seizure, with headache, vomiting, vertigo, and all these things. And we also look for if the patient has got ischemic or hemorrhagic stroke. So also we can look for the renal. If the patient has hypertensive emergency with there is no urine output, or the patient has got acute renal failure, or the patient has got azotemia. Azotemia is when the patient has got deranged renal function with no signs and symptoms. The fourth thing we look for ophthalmic examination. Whenever the patient presented to you with a hypertensive emergency, you always look for the end organ damage by doing the ophthalmological examination. The patient is complaining of blurred vision, the patient is complaining of vision loss, and then you can do the ophthalmoscopy in order to check the pupillary edemas. You will do all these things in order to check that the patient with hypertensive emergency is there any organ damage or not. If the patient has any organ damage, it means that is a malignant hypertension, that is a very severe hypertensive emergency, and we should act very quickly. If the patient BP is greater than 180 by 120, then it is very important to look for the end organ damage. And let's suppose the patient BP is less than 180 by 120, but it is hypertensive urgency. But if it is too raised, it is called hypertensive emergency. There is something which is very important to consider whenever you looking at the patient hypertensive emergency is the red flag sign. If these signs are present, you should quickly involve your senior consultant while doing the management of hypertensive emergency. So the red flag sign is either the patient is dyspneic, the patient is a very severe short of breath, either the patient is a very severe chest pain, or the patient has lost altered mental state, the patient is not its own senses, or the patient has any focal neurological deficit, like the patient is lost like weakness in the limbs, lower limb, upper limb, or any focal neurological deficit is a red flag sign in hypertensive emergency. So whenever the patient presents to you with hypertensive emergency, we do some investigation. It is not for all, but you can do it very case to case. But the most common investigation we do in hypertensive emergency is complete blood count, serum electrolytes, urine RE, lipid profile, ECG and chest X-ray, and CT brain. These are the common investigation we do in hypertensive emergency, but it is not important that we have to do all these investigations, but it's very case to case. Management of hypertension is very important, like understanding the hypertension. You diagnose the case with hypertensive emergency, and now it is time to manage it properly. So I will teach you how to manage hypertensive emergency. So in the first hour, our target is to reduce the mean arterial pressure over the greater than 25%. It is not same for all the cases. In some cases, we need more aggressive approach and greater reduction in mean arterial pressure. In some cases, we don't need a aggressive approach and don't need to be a greater reduction in mean arterial pressure. But the general rule is that we should reduce the mean arterial pressure greater than 25% in the first half hour. So our target in managing the blood pressure is that we reduce the BP to 160 by 100 and 2 to 6 hours, and then bring the blood pressure to the normal baseline in the next 24 hours. It's mean that whenever the patient with hypertensive emergency, it is very important to know that we should bring the baseline blood pressure level in the next 24 hours, not to drop the BP very acutely, because it will lead to the hyperperfusion of few a very important organ like brain, like kidney, so it will deteriorate irrespective of better. So it is very important to consider a very slow reduction in mean arterial pressure while managing the hypertensive emergency cases. Yeah, there are some cases in which it is very important to drop the BP very quickly, like the patient has preeclampsia. We drop the BP very quickly, like aortic dissection, pheochromocytoma, and hypertensive crisis. These are the few exceptions in which it is very important to drop the BP very quickly, irrespective of mean arterial pressure. While all other conditions, it is very important to consider to drop the BP very slowly in order to reduce the hyperperfusion in different organs. So how to select it is very important that which drugs to be selected while managing the hypertensive emergency. So there is some points, very important point, which you should consider while selecting the drugs for management of the hypertension. So the first thing is, what is your desire, how you like, what is your desire, that how much you want to the BP should be dropped. So this is the first step you should consider while selecting the drugs for blood pressure reduction. The second is the end organ system affected. Which end organ system is affected? Either cardiovascular system, neurological system, renal system, or ophthalmological system. The third is underlying disorder. Is this patient has any underlying disease, or the patient is normal and go into hypertensive emergency now? So the patient is either there is the presence of absence of any comorbidity, like the patient has chronic obstructive pulmonary disease, heart failure. So these are the comorbidities in which you will consider that which drugs will give me a benefits. Let's suppose the patient is asthmatic and now you give the labetalol to the patient, it will further deteriorate the condition despite of improving the condition. So the last thing is, what is the pharmacokinetic and adverse effect of the agent? It is very important to, whenever you prescribe any drugs, it should be very important for you to know the pharmacokinetic and adverse effect of their drugs, because if you don't know, it will further create the problem and will deteriorate the patients irrespective of better the patients. IV agent we use for the management of blood pressure is labetalol, hydralazine, nitroglyceride, and sodium nitroprusside. These four are the IV agent we use for the management of hypertension. So what is the dose of labetalol? The dose of labetalol is that you can give 10 to 20 milligram of labetalol within 2 minutes. And after that, you can repeat the dose of labetalol is 20 to 80 milligram after every 10 minutes until and unless you achieve the desired blood pressure. So here you can give the total dose is 300. You cannot go more than 300 because it will create a problem. So there is a very important thing you should remember while giving the labetalol is that the patient shouldn't be asthmatic, the patient should have chronic obstructive pulmonary disease, and patient shouldn't have heart failure, because if you give to this patient labetalol, it will further deteriorate the patient despite benefit the patient. So the second drug is hydralazine. We give the hydralazine as 10 to 20 milligram diluted in normal saline over 5 to 10 minutes. And we can give hydralazine after every 20 minutes until and unless we achieve the desired blood pressure control. Third drug is sodium nitroprusside. We can give this drug in a continuous infusion. So the dose for the continuous infusion is 0.3 to 0.5 microgram per kg per minute. but you can titrate this dose up to the 0.5 mg per kg per minute, but you shouldn't increase this dose from 2 microgram per kg per minute, because if you increase the dose, that this will create the cyanide toxicity. So here is the complete hypertensive emergency management. So I will discuss a few important condition in which hypertensive agent is important to give. So if the patient is aortic dissection, we need a very greater and effective reduction in blood pressure. So we give esmolol and labetalol. If the patient is pulmonary edema, we can give nitroglycerin and nitroprusides. If the patient is acute coronary syndrome, we give labetalol, esmolol, and nitroglycerin. If the patient has acute stroke, it is better to give labetalol as compared to nicardipine. This is a calcium channel blocker. If the patient is eclampsia or pre-eclampsia, we give hydrolazine either or labetalol. But hydrolazine are very good drugs in this case. But in our setup, we use labetalol. The patient is, I add these things intentionally that the patient has symptomatic drugs toxicity. What we can do, the patient has got a lot amount of sympathetic drugs, so it will activate the sympathetic system, it will raise the BP. So what we can do is to calm down the patient. For that, we give benzodiazepine. So benzodiazepine is a drug of choice for symptomatic drugs toxicity if it's lead to high blood pressure. So these all are the management of blood pressure. Hope you enjoy this and will learn a new thing from this. Thank you.